Okay, so the topic today is going to be mid-year protocol changes that go into effect on July 1st, 2017. Why are we doing this? Well, initially we really didn't want to make any changes to our protocol until January of 2018, but this spring, Nationwide Children's Hospital updated its recommendations for midazolam dosing for children having active seizures, specifically doses to be given intranasally for children with having seizures. In discussing this with Dr. Stevens, who's our Associate Medical Director for Pediatrics, she felt that it was appropriate for us to make these changes to our protocol now rather than wait until January 2018. Because of this change to intranasal midazolam for kids, there have been other changes that have kind of cascaded through the protocol, which force us to make some adjustments in the protocol. And in addition, we are facing some drug shortages specifically related to highly concentrated ketamine, which we use intramuscularly for behavioral emergencies, and for rocuronium that we use to chemically paralyze our patients to facilitate intubation. These drugs have become in short supply, so we felt that we needed to also make revisions to our drug substitution list, which is contained in the protocol, and to make some adjustments in our drug licenses to reflect these adjustments. So looking specifically at intranasal midazolam, this slide is a slide of the recommendations from Children's. This is their document, and it makes adjustments based upon the child's weight with pretty specific dosing recommendations. You should note that these doses are for intranasal midazolam using the 5 milligrams per ml concentration, which is the more highly concentrated midazolam. If you look at this, the doses are based upon weight, and it starts at 1 milligram for very small children to as high as 10 milligram doses for children who are more than 55 pounds. So when we looked at this, we tried to figure out how we would put it into our protocol, and we felt the most effective way to do this is to make adjustments to the medication atomizer device protocol page. And on this page, we directly list the doses for use in children, and we have also made adjustments in our dosing for adults. So this is kind of a coned down focused version of what's on the MAD protocol. We have adjusted the dosing for adults to 10 milligram intranasally, 5 milligrams per dose, again using the 5 milligram per ml concentration. We've also reformatted but continued the same content as Children's Hospital for the new dosing schedule with children. So children will get a dose of anywhere from 1 to 10 milligrams based upon their weight. So if you look at the pediatric seizure protocols, we have made adjustments in the dosing schedule, and at the bottom right corner is the dosing schedule for intranasal midazolam. And again, coning down and focusing on just that, we indicate that midazolam should be given intranasally if IV access is not present. But if there is an IV is already present, then you can use the intravenous route. But assuming that you arrive on scene and the child's having an active seizure, we will prefer, or the preferred route of administration is intranasally. Studies have shown that both in children and adults without IVs but suffering active seizures, intranasal or intramuscular midazolam works faster than IV midazolam, and that's solely because of routes or ease of administering the medication. As you approach patients with active seizures, I would look at them in a similar fashion to narcotic overdoses. Intranasal medication should be given promptly on arrival, and then you can work on IV access after the scene has settled down. So if you're facing a child or an adult with an active seizure, administer the appropriate dose of intranasal midazolam, check a quick fingerstick blood sugar to make sure they're not hypoglycemic, and then start concentrating on IV access. And as with all other patients, ABCs come first. Looking at adult seizures, it's the same perspective. Again, whether the patient is post-ictal or status epilepticus or having active seizures, if the patient is seizing, give them a dose of intranasal midazolam, obtain IV access, and then give additional midazolam only if necessary. I'd like to point out that for children and adults, the intranasal midazolam is a one-time dose only. If you look at behavioral, because of the midazolam adjustments, we felt we also need to make some adjustments in the ketamine. We've heard quite clearly that there needs to be some consistency between the protocols. So we have made adjustments in the ketamine dose intramuscularly for children and adults. So it's the same dose per kilo, and it is now 3 milligrams per kilo, IM, whether the patient is an adult or a child. So there's the same dosing schedule there. Same thing with children. It's again, ketamine is a dose of 1 milligram per kilogram IV, which is what we do for adults if an IV is already in place. If the child has no IV access, then the dose for ketamine IM for behavioral emergencies is 3 milligrams per kilogram. Looking at other reasons that we would use midazolam, we use it for cardioversion, and we use it for both cardioversion for wide complex tachycardia as well as PSVT or narrow complex tachycardia. Sometimes these patients may require immediate cardioversion, or you do not have immediately available IV access, in which case you can use intranasal midazolam. In this circumstance, intranasal midazolam for adults is at 5 milligrams intranasally. That's 2.5 milligrams per nostril. That's 2.5 milligrams per nostril. Again, if you have IV access already obtained, then you can use the intravenous dose of midazolam instead. So for cardioversion, the dose intranasally is 5 milligrams with 2.5 milligrams per nostril. And if you're going to give it IV, you can use 2 milligrams IV. You've probably noticed through this protocol that one of the things we did is we got rid of ranges of dosing of Versed or midazolam, and you'll see those changes in the 2018 schedule as well. So in the past, we had a dosing schedule of midazolam of 2 to 4 milligrams IV. We have now, at the request of many providers, just made a single dose, so there's no range of dosing. We also could use midazolam for sedation in patients who are bradycardic and requiring transcutaneous pacing. That can be very uncomfortable. For most of our patients who have bradycardia, we already have IV access established, in which case we can use midazolam at 2 milligrams IV or IO, and you can repeat it in 5 minutes if you need to. For patients who need pacing but there's difficulty in obtaining IV access, you can use intranasal midazolam at a dose of 5 milligrams total, again 2.5 milligrams per nostril, and only in the circumstance of bradycardia can the intranasal dose be repeated if it's needed. One other thing you may notice in this conversation about intranasal midazolam, for adults and bigger children, the dose of midazolam is 10 milligrams intranasally, but for everything else, the intranasal dose is 5 milligrams. Well, we've done that intentionally. If the patient's having an active seizure, we need to stop that seizure. If 10 milligrams intranasally stops the seizure but results in respiratory depression, then we can manage the airway by bagging the patient, intubating the patient if necessary, or using a rescue airway. In the other circumstances where we have midazolam listed, I really don't want us to be that heavy on the sedation, at least to the point where we need to worry about routinely worrying about the need for respiratory support. That's why for the other doses it's not quite as heavy as for seizure disorder. With these changes, we're also updating the medication information sheets for midazolam and ketamine, so that will be included in the protocol. So in summary, the changes that we are making to the protocol this summer have mostly to do with midazolam and ketamine. Again, look at the pediatric seizure dosing chart. For adults, the standard intranasal dose of midazolam will be 10 milligrams total with 5 milligrams per nostril. Both for the children and for adults, we're using the more concentrated form of midazolam, which is 5 milligrams per ml. For adult seizures, IV and IO midazolam is 2 milligrams. There is no range of what we had before of 2 to 4 milligrams, but you can repeat it. For cardioversion, the dose is, at least in adults, 5 milligrams intranasally, 2.5 milligrams per nostril. And for transcutaneous pacing, you can use the same dose if you do not have IV access, but you can repeat the dose times 1. For ketamine, we simplified things. If you need to use intramuscular ketamine, it's the same dose for adults and children, and that's 3 milligrams per kilogram. I'd like to remind you again that if the patient is having active seizure on arrival and you have no time for IV access, or IV access is not immediately or already available, go directly to intranasal midazolam and then obtain IV access as you can. If this results in some respiratory depression, then provide ventilatory support as appropriate with a BVM or intubate if it's severe enough. The other thing I mentioned is that we are changing or have updated our drug substitution list, and we've looked at medications that may potentially become unavailable. I've got listed here all of the drugs that have substitutes identified. Many of these were already previously part of the protocol. So atropine, dexamethasone, D10, fentanyl, we already had substitutes identified. For ketamine, if we run short on ketamine, and at this time intravenous ketamine or the ketamine at a more dilute concentration remains readily available, but if it was unavailable and we needed something for intubation, we would then substitute etomidate for ketamine. If we need something for intramuscular injection for behavioral issues, Haldol has been added to the list. Lidocaine, magnesium sulfate, and midazolam alternates or no alternates has already been identified in previous protocols. Same thing for naloxone and Phenergan. We have seen issues with rocuronium availability, in which case vecuronium or succinylcholine are available, at least as a drug substitute. This is what the modified list looks like. This is the first page, and here's the second page. Really, you won't hear anything else about these drug substitutions unless we need to make a substitution, in which case you'll be notified ahead of time. But I just wanted you to be aware of what we've done with the drug substitution list. So that concludes our brief conversation on protocol changes. If you have any questions or concerns, feel free to send them to me via email or post them on Workplace. Otherwise, at the end of this month or the first part of July, please make sure that you update the ResponseSoft app that's on your phone or tablet. Thanks for listening.